Okay, so this is the second PowerPoint on pain management. I'm not going to repeat anything that I just said in the other PowerPoint, an hour and 40 minutes long. So make sure you listen to the first one. And then also just what's new on this one. I won't repeat anything I said on the last one. Okay, so pain concept, any unpleasant sensory emotional experience with actual or potential tissue damage, right? So it doesn't have to be an actual damage, but it could be a potential damage that's causing pain as well. It could be, it is personal and subjective, meaning what the patient says it is, when it is, that is what it is. The patient is the most reliable indicator of pain and is the essential component of doing your pain assessment. So you got to talk to your patient if able. Most common reason for seeking health care. It is the number one cause for seeking health care. We talked about the effects of pain in detail. We talked about this in detail as well. Acute, chronic cancer versus non-cancer. What breakthrough pain is, right? And acute on chronic pain. Well, that may be the only one we didn't talk about. Acute on chronic pain, right, is a new pain different from the chronic pain itself, and it manifests itself. So the acute on chronic pain means that the patient now has an acute episode of pain on top of the chronic pain that they've had ongoing for over 6 months, but much, much longer, typically years. And so we do have to treat that pain on top of the chronic pain. So if a patient has chronic pain, for example, they come into the emergency department, they're already taking 60 milligrams a day of OxyContin, then you're going to need to give them something on top of that for their acute episode of pain, okay? So it's a common misunderstanding of new nurses that yes, we're going to start above that. We may give a different med and start, with a different dose, or we may go with, we're going to give that med and another med, right? Either way, the patient's going to need additional treatment on top of the 60 milligrams of their current chronic pain medication, okay? That's a key concept that you must get. We talked about all of the nociceptive pain. We talked about neuropathic pain. I will just mention, though, remember, it's damage to the peripheral or central nervous system, and it can be damage directly to it or dysfunction of the CNS, right? And it can occur in absence of actual tissue damage, right? And inflammation. Talked about all of that. We did talk about these different types of scales, right? And make sure you know them, right? PAIN-AD is patients with advanced dementia. We use what's called a PAIN-AD scale. And this talks about the different types of pain management. We discussed that in the last video. We talked about that as well. Okay. Analgesic agents, okay, non-opioid, again, we have acetaminophen, then we have NSAIDs, and under that non-steroidal anti-inflammatory drug department is ibuprofen, naproxen, and siloxib. We have our opioid or our mu agonists, again, like morphine, hydromorphone, fentanyl, oxycodone. Remember, our body produces that natural morphine-like substance, a small amount to have a protective coverage for our pain, right? And then when pain is beyond that level, we need to give a mu agonist like morphine or oxycodone or something along those lines. We also have opioid non-mu agonists medications, which are their actual agonist antagonists, like buprenorphine or butyrophenol, okay? Adjunctive analgesics, I do want to mention lidocaine patches. They're great for localized pain in certain areas. Anticonvulsants, we talked about again in the last video. I'm not going to cover them again in detail, but gabapentin's a good one you should know. And then, of course, ketamine, right? And ketamine, when used in really low doses, is a good analgesic. Again, anticonvulsants work on the brain chemistry as well as the receptor sites, right? And we use it mostly for nerve pain. We are going to watch for therapeutic drug levels, and it, like almost every drug, it has a maximum daily dose. So we're going to be very careful to not go over that daily dose. Antidepressants, again, work on the brain chemistry, and it reduces the patient's perception of pain. Some of them do have a risk of suicide that we have to educate our patients about ahead of time, and family members, so that they can all watch out for those kind of behaviors and thought processes. They can change mood and behaviors. They do have therapeutic drug levels. They take up to 6 weeks, so it can be anywhere from 2 to 6 weeks for the patient to actually start seeing a difference, but they need to give it time to work, because it does take time to work, and we do need to monitor these patients very closely for the first few months, because we're going to have to titrate those meds up, because it's one of those start slow and go low, which is what we do with most of our meds. Start slow and go low, titrating up. We do have nervous system sedatives that we talked about in the last recording. So just remember that it does decrease the neural transmission and thus reduces the patient's pain perception. It can cause sedation, so we want to use the same safety rules that we talked about in the last video. Watch for changes in the patient's LOC, and then again, watch for suicidal thoughts, because that's a side effect of some of them. It is good to make aware that there is a physical dependence component at times for opioids, right? So, but that doesn't develop, right, unless patients have been on them consistently for over 2 weeks. So we can educate our patients about that in the hospital many times. They're not going to be on the med long enough to develop a dependence. Now, that's not everybody, I get that, but it's the majority of people, right? And when we say physical dependence, we're talking about the physical withdrawal symptoms that patients will get. They don't get those typically if they haven't been on the meds for around the clock for 2 weeks. Tolerance is a normal response within everybody's body with regular use of many medications, right? So when you use certain medications, you will develop a tolerance over time. And what that means is it has less and less of a therapeutic effect with the same dosage over time, right? So as a result, there's a decrease in one or more of the effects of that med with continued use. So as a result, we will need increased dosages to get that same therapeutic pain relief effect, okay? And then finally, we have addiction, right, which is behaviors that are characterized by the need for the drug due to its psychogenic effects. So, so again, they get addicted to the therapeutic use of the opioid. And honestly, the addiction is negligible. So this doesn't occur very often. And, you know, with some patients, it's irrelevant, like your end of life. Doesn't matter if they're addicted to it, they need it, right? But again, it's negligible at best for most. Substance use disorder is when there's an impaired use of a substance, even while experiencing major problems. So they continue to use it despite it harming them, or, you know, they have a craving and all of that, right? Or they're using opioids for non-therapeutic reasons, right? So not to relieve pain, but for other reasons, right? And it can be influenced by genetic, psychosocial, and environmental factors, right? Because some patients are genetically predisposed to addiction. It's a fact, right? It's been proven. We know psychosocial factors that will encourage some patients to have substance use disorders, right? And then definitely situations in the environment can lend toward people becoming, you know, having substance use disorders. So it is a factor sometimes, right? We've already talked about gerontological considerations in the last video, so I won't cover that here. So obviously we need to identify goals for pain management. We need to establish that trusting relationship with our patient initially. Do lots of education about pain management, staying ahead of the pain, we need to manage the patient's anxiety about the pain meds. And I discussed this in detail in the last recording, how having a plan and a schedule that you put on the whiteboard will help reduce a lot of the anxiety there. And then just evaluate the pain management strategies. And if it isn't working, then change them, right? It is very important that as nurses we recognize the adverse effects of analgesic agents. So respiratory depression is a risk of opioids, right? We know that. That's one of the main risks. Respiratory depression and bowel constipation, right? So if we use our opioids smartly, we don't usually have to worry about respiratory depression, right? Start slow, go low, right? Sedation. Again, use the previous sedation scale. Nausea, vomiting. It's a rare side effect of some opioids. If it occurs with one, then we just switch the patient to another one, right? You have a conversation with the doctor and you get a different opioid, right? But again, it's a rare side effect. Constipation, though, is not rare. It happens with many, many opioid medications. So we naturally almost always give a stool softener with our opioid meds. We just prophylactically, I should say, just have them take a stool softener and drink plenty of water to keep the bowels moving. Excuse me. And then we also will get a PRN order for a lubricant or emollient enema, so that if they get bound up, they can, get the bowels moving, because we got to have bowels moving, right? And then pruritus or itching is an adverse effect of some analgesics, but for only some patients, right? So it's, the serotonin release. So what we would do is literally give a serotonin antagonist to them, so to cover the itching, or put them on another different opioid. But if they're going to have pruritus with one, they may have it with most of them. Excuse me. Obviously, it's a collaborative approach to treating pain, and obviously we have to use evidence-based practice, and it's very comprehensive, and we've discussed that in the last video in detail. There are some non-pharm measures that patients and families may be on: herbs, botanicals, vitamins, probiotics. We talked about that a couple weeks ago, right? So we need to be aware of those as well, and always asking about over-the-counter things that patients take to help with that. And we talked about the mind and body practices in our last video with massage therapy, acupuncture, and all that, right? So we won't cover that now. Whoop. Talked about cold and hot packs. Again, in massage therapy, we talked about acupuncture, aromatherapy. We talked about imagery. Remember, it can be self-guided by the patient or by us. Again, they're going to think about their favorite time, place, or event. And we're going to talk about the images and what they see in detail and how they provide comfort. While we're doing this, we're going to have them breathe in deeply through their nose and out through their mouth, and it really will calm them down many, many times. Distraction, again, allows the patient to focus on something else while experiencing the painful episodes. It could be TV, puzzles, games, knitting, network, all these other wonderful things that we could be doing, and it does lessen the patient's perception of the pain over time, okay? And then music therapy. Obviously, some facilities have trained musical therapists or people who volunteer their time. And it really does help when patients are having painful episodes for us to turn some background music on for many of the patients. Sometimes we find out it makes it worse, right? So we just turn it off if that's the case. But usually it will provide some distraction on some level and some enjoyment. You just got to find out what type of music they like, because if you put the wrong music on, that can irritate some people, right? Yeah. And some patients even like to sing out loud, which is awesome. And I sing out loud sometimes just to entertain people. Okay, this is the end of this chapter. Thank you.